At least not that we can see it on the face of it. You know, the government's learned its lessons. The American people are smart enough, and the American people are principled enough not to want those things. So what do? They just co-opt the normal structures that we all live with. Everybody remembers you can keep your doctor if you want to keep your doctor. Well, if he hasn't retired or left, 46% of doctors say they're going to leave the practice of medicine if this all comes to fruition. What if he doesn't work for you anymore? What if he's in his office and he's been contacted by a new accountable care organization, he's going to be accountable. All the insurance companies that any of you are on have signed up with the accountable care organization such that the payments to that doctor go through this structure. The structure lives with guidelines set up by the U.S. Preventative Task Force. Does everybody remember the mammogram rule? Anybody 43 and thinking they might get a mammogram? Well, maybe not. You know, it's not cost effective according to the federal government. By the way, did you all know that on the panel that made that decision, the U.S. Preventative Task Force on Preventive Services, there weren't any oncologists on that task force or radiologists on that task force. But they, in this law, have the authority and responsibility to set guidelines that all of these accountable care organizations are going to have to comply with if they want to get paid in the way they expect to get paid. So all of your doctors are going to be told, well, you may have a relationship with that patient, but your compensation is based upon whether these accountable care organizations think you're doing what you have to. The accountable care organizations are not, by and large, going to be physician-owned. There might be a few large physician practices that can establish them. But by and large, you're going to be hospital systems, insurance companies, things like that are going to kind of get together and form these groups. And what's their incentive going to be? Well, they want to maximize their pay. Whether there's doctors in charge of them or insurance people in charge of them, those executives are going to be paid based on how their organizations perform. And how they're going to perform is how closely they adhere to these guidelines. These guidelines are going to could be designed specifically for cost effectiveness or for control of some sort. So is your doctor still your doctor? Even if the office looks the same, the furniture is still the same, he's wearing the same grungy old white coat that he always wore. But if his pay structure is based upon whether guidelines that may or may not apply to you, but those guidelines are, he gets paid whether they're followed or not based upon whether or not the accountable care organization approves of what he does. So that's the first question. Is your doctor if they work for somebody else? How do they do this? So I'm trying to paint a picture of how all of these structures are now in place for a totally different way of looking at medicine in this country. How do they do this? Stimulus bill. There are a couple of things in the stimulus bill that most people don't know. It wasn't just about stimulus. Well, we know that. Buried deep in the stimulus bill were two critically important aspects of putting all of this healthcare, how to put us in a socialized healthcare system, which, again, I will tell you, we are in as we speak. These laws are passed. We live with them right now. My letter came. I'm being assimilated. How do they do this? Well, I think the most important thing that was in the stimulus bill that puts us all in a very difficult situation relates to electronic medical records. Now look, I'm a techie. I learned to program computers on punch cards back at Highland Park High School in 1979. I love computers. We have electronic medical records on all this. Software that we purchased, that we've helped design, that we've set up with things that we think do a better job of providing medical care. Our nurse gets a reminder. She's supposed to ask you if you smoke when you bring your kid in, because we like to tell people to stop smoking around the kids. There's things that we do that it helps us remember to do well. We like being able to look up, for example, who needs a whooping cough booster, since we're by the way, we're all in the worst whooping cough epidemic since 1956. And as pediatricians, one of our everybody move away. And yes, adults are just big kids, so I can provide. We like to be able to say, hey, there's 4 or 5 kids in the practice who are particularly medically susceptible to whooping cough. We know who they are because we've been able to pull them out of a database. Get them immunized. What the stimulus law did, though, is create the office of the National Coordinator for Health Information and Technology. This is a guy named David Blumenthal, who's a doctor, who's this guy. He's the healthcare record czar in this country. Within the next few years, all of your doctors are going to pretty much be arm-twisted by their reimbursements, which they won't get if they don't do this, into having electronic medical records with databases that are all compatible. The databases are fully intended to live on government servers. The government servers are going to be connected to decision-making people or decision-making software to implement all of these guidelines that are going to come out of the federal government. So when the time comes for you to decide whether or not, with your doctor, you want your mammogram. And my mother had breast cancer in her 30s. I think I need one sooner. The absolute intent of this, not just recently, but going back for a very long time in the minds of the folks who want us to have a centralized, government-controlled healthcare system, has been that it's going to happen through your electronic medical records. So you start seeing the pieces come together. We have the healthcare record. It's going to be on a little tablet in your doctor's lab. It's going to be connected to a database on a government-controlled system. Government's going to have these U.S. Preventative Task Force and other organizations that are going to make decisions about healthcare. They're going to communicate to you real-time, your doctor back and forth, as to what kind of care you're going to be allowed or not allowed. And the question came up, what happens to Medicare, where that $500 billion comes out of? That's how it happens. There's another interesting part of it in the stimulus bill. It's called comparative effectiveness research. Has anybody heard of that? See, these terms are really fascinating to me. Comparative effectiveness research, that's cool. I want medical care that's more effective. What it is we now have a council, so all the members have been appointed. The funding for them doing this is all, both in the stimulus bill, it's also in the federal health care law, the Patient Protection Affordable Care Act, is that the government is going to decide through research, they're going to pull information out of your health care record, not going to ask you permission, not going to get your consent. They're going to pull information out of everybody's health care records and say, well, what's the most cost-effective way of doing some of these things? Do we think people should be getting mammograms or not mammograms? Or stress tests, or implantable defibrillators, or something like that. They're going to data mine all of this. And more of these decisions are going to be made centrally. That serves two purposes. One, it robs you of control. All of you people making your choices for all this expensive care, you won't be able to make those choices anymore because your doctor won't work for you. By the way, I'm at 15 minutes. All right, I'm going to ask a couple of questions that will give you the insurance side of things, which is equally dire. Here's a question I want to leave you with as you think about this going forward. I've painted a picture